Good morning, everyone. It's great to have you here this morning. I'm going to give it one more minute or so, just so we make sure we have folks coming in and they have a little um, buffer time to get into the webinar. I hope you all are having a great morning. Make sure you get your cup of coffee, hence the lungs. You're going to be learning a lot of very valuable information this morning. So we're very happy for you to be with us. So get your cup of coffee and notebook ready, and you'll have this incredible time this morning. Time well spent. All right, so let's get started. And I'm going to introduce myself and what the movements are this morning. My name is Jennifer Wescoe, and I'm the Executive Director of Wescoe Foundation for Pulmonary Fibrosis. And some folks who are on our call this morning might not have heard of us. And so I just want to give a little bit of a background of who we are. We are a nonprofit organization, and it is intrinsically woven into our organization. My dad, Ron Wescoe, had pulmonary fibrosis. And we felt lost, we felt overwhelmed, and we had an opportunity of making sure that people are moving forward and getting the support and education that's incredibly valuable in navigating interstitial lung disease, ILD. So we have Wescoe Foundation for Pulmonary Fibrosis, and we focus on the education aspect of this journey, the support, the resources, the advocacies for people who are living with pulmonary fibrosis. Also, the care partners who are so valuable in this whole big picture, and our healthcare professionals. And that leads me into this great honor to work with Temple Lung Center and to be able to be a part of this webinar, and understanding the value of this very strong collaborative partnership. My dad was a patient at Temple Lung Center and was treated with the utmost respect and dignity. And ever since then, we've come together and have done incredible work together for our community. And so it's such an honor to be here and be with you this whole morning and learn this very valuable information. So we have our agenda. And before we go to the next slide, I want to kind of bring it together in terms of the goals we're trying to accomplish today. And we often talk about quality of life. So we're living with ILD. And so we really want to focus on heightening, making sure this is always part of our conversation in all the things that come along, in making sure our quality of life is the best it could possibly be. And so if you could go to the next slide, we're going to share with you our agenda. And we are in the time, wherever you are in the progression, initial diagnosis, navigating ILD, looking into other ways in the management of it all. But we always have to start at square one, right? What is ILD? What is interstitial lung disease? And understanding your diagnosis. So a lot of part of this journey is the education equals empowerment. So you have that to move forward. So you have these great conversations with your pulmonologist, and any healthcare professional whom you work with, who's on your care team. So We have our first um, talk, and it is what is ILD? What is interstitial lung disease? Understanding your diagnosis. And so we have Dr. Rachel Criner, Assistant Professor of Thoracic Medicine and Surgery. And Dr. Criner will be educating us about ILD. The next talk about, again, keeping in mind quality of life, right? What's the day in? What's the day out of managing ILD? And a lot of part of that is symptom and oxygen management. So how do we handle fatigue? How do we handle our cough, persistent dry cough? When we're using our oxygen, what are the steps along the way? Why do we need oxygen? How do we manage it? And our presenter is Dr. Ajmeri, Assistant Professor, Thoracic Medicine and Surgery at Temple Lung Center. And Dr. Ajmeri is going to be sharing with us ways in managing this and identifying them. And again, get your pencil and paper out, make sure it's right next to you. So thank you to Dr. Ajmeri educating us in this very important, another very important topic of symptom and oxygen management. The next part of the morning, we're going to be talking about pulmonary rehabilitation. And this part of our journey, again, is very important to keep us conditioned. But why do we need it? What's the importance of it? What does it entail? So Dr. Pourshahid is going to be talking about pulmonary rehab, yet another topic to take back to your pulmonologist to have this conversation. We also have a very dear friend of all of ours, is Dennis. And Dennis is, we always want to talk about the patient voice, the people voice in this journey. And Dennis is one of our wonderful people we work with every day with Wescoe Foundation, Temple Lung Center, and sharing, Dennis is going to be sharing his experience living with pulmonary fibrosis, ILD, and what he's experienced along the way. Yet again, another opportunity to identify what you're experiencing and what other people are experiencing living with ILD. Next slide. A lot of part of this process are clinical trials. They are vital. They are our future, and clinical trials, what's happening, what's occurring in our research world. And so we have Dr. Gerard Criner with us, Chair and Professor of Thoracic Medicine Surgery, Director of Temple Lung Center. Always such an honor to have Dr. Criner educate us about the need of clinical trials, what's happening out there, how do we get involved for now and our future. Next part of our agenda is lung transplantation through this whole journey, and we'll have Kevin Carney, and Kevin is the nurse practitioner, pulmonary nurse practitioner, Temple Lung Center at Temple Lung Center, but the lung transplantation team, the whole part of that. And so we're lucky to have Kevin with us, educating us about lung transplantation. And then next we'll have is the journey ahead. Part of this whole folding of living with ILD, right? Pulmonary rehab, understanding the disease, clinical trials, symptom management, oxygen management is supportive care. And so when we have the fold into this, we're going to bring the fold into supportive care support groups and resources. How do we get connected? How do we manage this moving forward? So myself and Michelle Vega will be talking about what are the parts of this? Why is it important? And so it's very essential in our journey. So we'll be talking about that. And lastly, what's really great about our webinar today is the interaction, right? the Q&As. We have a lot of questions. So when you go through this agenda, make sure you write your notes down and have them ready for some Q&A. And if some questions are not exactly answered at the time, that's okay. We'll start post-webinar. We'll get some questions at least in the right direction. In our break time, we will have a poll. And we'll be asking questions. We want to understand a little bit more about what you're experiencing. So in between that, we're going to be having a bit of a break for about 10 minutes. So we're going to put a poll onto the webinar. So just to kind of line up of what the morning is going to look like for everyone. Again, we're so happy that you're here. And we're really looking forward to moving forward. We are going to start our presentations with Dr. Rachel Criner and talking about what is ILD and understanding your diagnosis.
Hi, everyone. My name is Rachel Criner. I'm a pulmonologist here at Temple, and I have interest in interstitial lung disease. So today we're going to talk about, what is interstitial lung disease, or ILD, going over the pathophysiology, that is, the background of how this disease happens in your lungs, as well as what are the causes, what are the treatments, and how do we monitor you going forward. So let's start with what do the lungs look like with interstitial lung disease before we talk about how the disease actually happens. So this scan here on the left side are healthy lungs. So this is a left lung, this is a right lung, and these nice, fully black lungs. This is a slide of a picture of a patient with interstitial lung disease. And you can see that it's much different than the picture on the left. There is a lot of white markings. There's a lot of kind of nodular airways. This is all scar throughout the lungs. So what is interstitial lung disease? It really is a umbrella term that encompasses several diseases, over 100 different subtypes. But all of these diseases cause the same process. They cause inflammation, and over time that can lead to scarring or fibrosis. When we're talking about interstitial lung disease, where is it happening in the lungs? The lungs are full of these air sacs, and at the edge of the air sacs are blood vessels. Between the air sacs and vessels is this interstitium, and that is the site where we get this inflammation and over time can get the scarring or fibrosis. So some patients might just only have inflammation. Some patients might have progression to scarring or fibrosis. This is a very kind of quick and dirty way of thinking of what happens with ILD, but it is much more complex. This slide isn't for us to know and review and memorize all the mechanisms behind the inflammatory pathway that gets set off with interstitial lung disease. But the reason why I want to highlight this is for everyone to know that there are multiple proteins, multiple factors that are involved with this inflammatory process, that over time, this constant inflammation will lead to scarring. This is important when we talk about treatment and really research opportunities. I know there's a topic later in the day, because now we know the pathway better of how ILD happens. So now we have specific medications studied to target parts of this pathway. So I mentioned that there are over 100 different subtypes of ILD. These are just a few of the causes, the more common causes. But many of you might have ILD from causes that are not even listed here. A big category of diseases that cause interstitial lung disease are autoimmune diseases. So someone might mention that they have rheumatoid arthritis or scleroderma or muscle problems called myositis. Occupational exposures is a major cause of interstitial lung disease. So that's why when we're evaluating you in clinic, we're often asking, what was your upbringing? Where did you live? Did you live in a farm setting? What was your job? Asbestos, silica, metals, coal, all of these can cause interstitial lung disease. Things in your environment, whether it's in your home environment or your work environment, can also cause interstitial lung disease. Typically, this is a pattern called hypersensitivity pneumonitis. A big factor can be mold. So we'll often ask, have you ever had water damage in your home? Do you ever have mold in your home that had to be remediated? And bird droppings and feathers is also a particular cause. So people with chicken coops, farmers, this can be a common cause of interstitial lung disease. Then there's this whole subset of other, and many things are grouped into other, and there's an even longer list than what I have here. But anything from acute respiratory distress syndrome, so ARDS, which happened frequently after COVID, genetic reasons, sarcoid, among others. And then a large bucket is idiopathic. Idiopathic pulmonary fibrosis is a specific cause of interstitial lung disease. There's also cryptogenic organizing pneumonia, which is a cause of ILD that we don't know how it happens, but you get a pneumonia-like picture to your lungs. IPF is highlighted here because this is the most common cause of interstitial lung disease out of all of those many, many causes. It's almost a quarter of cases, so almost 25% of cases of ILD, patients will have IPF. So just some statistics to review of some general information about interstitial lung disease in general. It is a rare disease. Some could say maybe almost an orphan disease. It's less than 1% of the US population. The latest data we have is from 2021. So it is not common. Most people are around about 69 years old. So I typically see patients in their 60s to 80s with ILD as a new diagnosis. It's equal in men and women until they're over 75 years old, when it predominates more in males than females. And unfortunately, the survival is not good. So IPF, idiopathic pulmonary fibrosis, that's the disease I mentioned that's most common. That unfortunately has can have a rapid progression. The average survival is anywhere from 2 to 5 years, but typically it's about 3.8 years is what's been reported. The non-IPF, so pretty much everything but IPF, those patients also have a similar prognosis, more around 2.5 to 5 years. Why is the survival so poor? The survival is so poor because the fibrotic disease can be very rapid, but also people can have what we call flares, which I'll review towards the end. But that means sudden worsening in your respiratory disease, and that can make you sicker from already your baseline. So what symptoms may you have with interstitial lung disease? I will say that there's a large group of patients who don't have any symptoms, and they find out that they have interstitial lung disease when a CAT scan or a chest x-ray is ordered for some other reason. For example, maybe you have shoulder pain and you get an image of your chest, and that image of your chest happens to notice these changes that we would call interstitial lung disease. But many patients do develop symptoms. That could be shortness of breath, a dry cough, and just overall feeling very tired. This can be subtle. You might notice maybe 2 years ago you could do your yard work, and then this past summer maybe you couldn't use your mower anymore, you couldn't do your weeding. That's oftentimes where people will come to me where this has actually been going on for a couple of years, and they just kind of subtly had some changes and didn't realize that these symptoms were related to their underlying interstitial lung disease. So how do we diagnose your disease? So CAT scan is really the main thing that we need. There are other tests, but you absolutely need a CAT scan because that's the only way that we can get a good picture of your lungs to see if you have interstitial lung disease or not. We use breathing tests as well as walking tests. The breathing test lets us know, do you actually have lung dysfunction from the changes we see on the pictures of your lungs? And if so, how severe is your lung dysfunction? And then we also have you walk because we need to see if your oxygen levels drop, whether you're sitting or then walking. That will tell us that you have more severe disease if you're starting to require oxygen. Labs are used more for the workup of interstitial lung disease. So I mentioned on one of the prior slides that there are several autoimmune diseases that can cause ILD. So we get your blood to check for all of those autoimmune diseases because you might have rheumatoid arthritis without joint pain, and your only manifestation could be your lung disease. What about biopsy? I often have patients come and ask me if they should be biopsied for interstitial lung disease. Biopsies used to be more routine, but now it really should only be considered if it's going to change the management of your disease. And so it should be a case-by-case decision. The reason why we don't have everybody get biopsies with interstitial lung disease is, one, there's a high risk for your lung collapsing, which is a pneumothorax. There's a high risk that you're going to actually have bleeding, more so than the general population. And there's a high risk that the procedure itself will lead to a flare or acute exacerbation. I mentioned on a prior slide that flares are often a reason why the prognosis of ILD is not great, because they can make you very, very sick, require you to be hospitalized, require you to be on oxygen or more oxygen than you previously are. So my practice is I really don't put patients towards a biopsy unless it's absolutely going to change how I manage the patients. So speaking of management, what do we do for interstitial lung disease? So unfortunately, there's currently no cure. There's no cure for this disease. And there's only 2 medications on the market. These are called antifibrotics. And these medications don't reverse your disease. They can slow down your disease, but they don't reverse it and they don't cure it. They also, the other goal of treatment is not to just slow down your disease, but to also prevent you from having flares. And as I have mentioned a couple times before, flares can worsen your disease and make you sicker. This is a patient who presented with a flare. So this is their left lung, this is their right lung. You can see that they have a lot of kind of gray on top of all the white markings. Then they were treated with steroids for their flare. And you can see that they still have all these white markings, which is their scarring, because that does not change. But all that gray, most of that has gone away. So management. This is to show you that there are multiple things that we are doing at once for patients with interstitial lung disease to manage their disease. So I mentioned medications. So if you do have the inflammation part of your ILD, we have medications to put you on. Those are typically prednisone or mycophenolate, which is Cellcept. And then there's antifibrotics. As I mentioned, there's only 2 on the market approved by the FDA. Those would be Ofev, which is nintedanib, and the other one is Esbriet or pirfenidone. We always want to put you on oxygen if you need it, because over time, the purpose of the oxygen is actually to protect your heart. We enroll patients in pulmonary rehab. The most important thing is to move, not to stay sedentary, but to move, because over time, your interstitial lung disease can make your arms and your legs really, really weak, as your lung muscles kind of take all your protein and all your calories. And so the lung muscles do a lot of work, but then the arms and legs can't do as much work as they need to. So we want your whole body to stay strong. We turn to lung transplant consideration early for ILD. And the reason being is because you can have these sudden flares that are unpredictable and make you very, very sick, where sometimes transplant's no longer an option. So many patients, when they first come to us, are considered for transplant evaluation, because we want to make sure that we're evaluating you before you get too sick. There is many support groups. There is many online support groups that maybe during the Q&A can give you some names for, because although this is a rare disease, there's actually a pretty strong community online for patients with ILD. Vaccinations, all ILD patients need to be updated on their vaccines, because any of these viruses can increase your risk for flares. And then clinical trials. I know there's going to be a talk later about clinical trials, but I just want to highlight that, as I've mentioned, there's only 2 medicines on the market for scarring for ILD, and you're only on one or the other. Beyond that, there's nothing else approved. Where we are with ILD research now is where cancer was about 10 years ago. So I showed you that picture in the beginning with all of the various pathways involved with ILD, inflammation, and fibrosis. We're now having studies with medications that specifically target certain parts of that pathway, which is pretty much what cancer treatment studies were 10 years ago. So now we're doing more targeted therapy, and that's what a lot of our research is now devoted to. A lot of these medications have been proposed to either stop progression or reverse progression, which is something we haven't seen yet for ILD. How do we monitor you, though, going forward once we know that you have ILD and once we have you on a management plan? The most important thing is that you're seen by a pulmonologist every 3 to 6 months. This isn't something that you see a lung doctor for one visit and you don't see them again. That's because your disease can progress. So we have patients be seen every 3 to 6 months by the lung doctor. They get a breathing test every time, and they get a walking test every time. And this should continue lifelong. Okay, thank you for your attention.
Thank you, Dr. Criner. That was very, very informative. I super look forward to the notes that you're writing and any questions that you have. Incredibly informative. Thank you, Dr. Criner. Our next presenter, Dr. Ajmeri, is going to be talking about the day-to-day symptom oxygen management and managing that in a way that's practical and useful, and the questions of why do we need oxygen, etc. So, and I also want you to keep in mind, everybody who's on the webinar, you are at different parts of the progression of ILD. Take that in consideration of looking forward, things that you did not know before. So without further ado, I'd like to introduce Dr. Ajmeri.
All right, thank you, everybody, for being here. Like they said, my name is Aamir Ajmeri, one of the pulmonary attendings at Temple. So I just wanted to talk today a little bit about management of symptoms and a little bit of the nuts and bolts of oxygen. So just to get started, so pretty much with any interstitial lung disease or pulmonary fibrosis or IPF, really what our goal is to make the diagnosis. And as most of you all know, that there are many different causes of interstitial lung disease. And so our job is to kind of find out what the etiology is. And so once we have the etiology, that's when we can talk a little bit and focus more so on the management of these kind of complex diseases. But there's more and more interest and research going into this treatable trait approach. And so what that is kind of focusing not so much on diagnosis and management of the inflammation or the fibrosis or the scarring, but it's more so about what we can do to treat similar symptoms in patients who have these diseases. And really, when we treat these symptoms, we can help with improving quality of life. And so a lot of the symptoms overlap between, the many different interstitial lung diseases. And so that's why it's important to kind of recognize that and think about what we can do to treat these symptoms. So I thought this was a nice figure from this paper down here, but it's kind of what patients and caregivers for patients with interstitial lung disease kind of need. And so as you can see down here, it's treating with medications, with antifibrotics, with anti-inflammatories, clinical trials, but that's not really what we're going to focus on today. So we're going to talk a little bit about these symptoms here. So feelings of shortness of breath, fatigue, cough, anxiety, depression, using supplemental oxygen. I know there's a full session on pulmonary rehab, so I'll just touch on it, not really talk too much about it. And then support for patients such as yourself going through, dealing with these rare lung diseases. I'm not going to talk too much about end-of-life care today. So I think the first thing to talk about is oxygen. And so, there's a lot that goes into using supplemental oxygen when your oxygen saturation is not where it needs to be. So what we know, and it's been studied, is that oxygen desaturation, or when your oxygen levels fall lower than 90%, it contributes to decreasing exercise ability. So when you're kind of living in these low oxygen saturations, you won't be able to exercise as much. However, there's been studies that show that if you have patients who desaturate when they exercise and they are given oxygen, supplemental oxygen, to maintain the saturation greater than 90%, it really improves a lot of outcomes. So it leads to patients being able to walk farther distances. They feel less short of breath. They feel less fatigued. They feel like they have more energy and they're able to do more things because their oxygen is now in a normal range. There's a lot of kind of stigma and, opinions and attitudes about using oxygen, which we'll touch on a little bit. But, it's one major study, they showed that patients' attitudes changed a lot after they started using the oxygen and they saw firsthand the improvement in their exercise ability and their quality of life. There's also data that support using supplemental oxygen leads to decreasing cough incidence as well. So talked a little bit about, roadblocks, or, what are the thoughts and feelings about using oxygen. So I hear a lot of patients say these things, and I think a lot of you would kind of feel similar, but kind of psychological burdens. It leads to more anxiety, more depression about kind of disease, and that you feel like this is your disease and symptoms are getting worse. There's the realistic fear of running out, that what if you're out and you're doing things and your concentrator runs out of oxygen? What will you do then? So people constantly are checking pulse oximetry, checking how much is left in the tank, having backup batteries, having backup tanks, feeling that, what's the worst case scenario if I run out? And that's a real thing that patients talk about a lot. And then there's, feeling embarrassed, or feeling like, everybody can kind of see my disease when I'm using oxygen. You can't really hide it. And people can definitely be embarrassed and have the stigma behind using oxygen in public. I mentioned that if you're using oxygen, you're at that stage where now you need supplemental oxygen. You feel like the disease is worsening, even if it's, been there for some time. And then it's complicated. There's a lot of different companies out there. There's a lot of different modalities that we use to deliver oxygen, and it can be overwhelming and anxiety producing to go through all of that. We'll talk about that a little bit. But this is what I tell every single patient that I have on supplemental oxygen, and it's the same line I say to everybody. But you can't think of oxygen as something that's holding you back or making you worse, or you're reliant on oxygen or anything like that. But it's really something that it will allow you to do more activity and allow you to lead a more fulfilling life, and more a life with more higher quality as well. So, it's trying to shift that mindset into, this is something that, I'm tethered to this oxygen machine. I have to use it all the time, but really it's for the benefit of being able to do more and experiencing more that life has to offer. So I want to talk a little bit about the nuts and bolts of using supplemental oxygen. So when you get your oxygen prescription, it's going to be, it will say kind of the type of flow. And so there's two main types of flows. There's continuous flow and pulse flow. And so flow is how much oxygen you're getting in liters per second. Their continuous flow is in the name, it's continuous. So you'll continuously get that same amount of flow all the time. It doesn't change. The benefit is that you're getting flow in inspiration and expiration, but it takes up a lot more energy of the machine, and it uses a lot more oxygen to do that. So generally that goes up to 3 or 4 liters, and then when you need more than that, then it goes to pulse flow. And pulse flow is that when you inspire or take a breath in, the machine will deliver oxygen in through the nasal cannula. Patients may not tolerate it as much. They may need the continuous flow to feel better and be able to do the exercise. It conserves more oxygen, so you're not using as much all the time. But some patients tolerate it just fine. And so it's really just a discussion about what works for you. When we write oxygen prescriptions, there's a couple things that we write on there for the companies to use so that they can deliver it to your home. So when to use it. So is it during sleep? Is it during rest? Is it with activity? Is it with all the time? So we always indicate that. Flow amount in liters. So talked a little bit about that. So what number you're going to turn it to, which is the flow in liters, and then the type of equipment. The types of equipments, so there's a whole number of them. We'll talk about them a little bit. So there's a stationary concentrator, there's the portable concentrator, there's tanks, there's cannulas, there's tubing. So it can get a little bit kind of hairy and a little bit overwhelming, but we'll try to go through each of them in a little bit of detail so you're more familiar with it. So here's some of the devices. So the stationary concentrator, so that's the big machine that you keep in the home. It stays in one room. It uses electricity. You plug into the wall in your home. And what it does is that it takes oxygen from the air. It kind of distills it out. It pulls it out and then delivers it through the tubing. And then you have tubing, which is various lengths, which you can use all throughout your home. You can have, there's two main different types. There's the low flow, which goes up to about 5 liters, and then there's the higher flow, which is uses more oxygen, more electricity, of course, which goes up to about 10 liters or so. But that's in your home. That's what you use, when you're in the majority of the time when you're at home, and you have, tubing that you walk around with throughout different rooms in the house. They're stationary liquid concentrators, so they're not as large. They don't require as many part maintenance and things like that. What it is essentially is that at really low temperatures, oxygen becomes a liquid. And so as it warms up, it becomes a gas again. It's not very common. Not a lot of people use this. It's not offered by a lot of different companies. It's very expensive. It needs to be refilled weekly. So yes, it's a little bit less cumbersome, but it's a little bit more expensive, labor intensive, that kind of thing. So compressed gas tanks. So most people probably will have this. So these are the small tanks that you would travel with, and it has a specific amount of oxygen that's in there. They have small tanks. They have larger tanks if you need higher flow rates. They have different ways that you can walk around with them. So there's the rolling ones. They have the backpack ones as well. But this is really what most people will end up using when they're out and about doing activities, exercising with supplemental oxygen. Now, over the last years or so, there's more and more usage of portable concentrators. So portable concentrators are great. They are really small. They're very lightweight. You don't have to roll them. Most of the time, they just are a small strap, and you can walk around with them. But there's a couple downsides. They run on batteries. There isn't so much that you can, there isn't as much higher flow rate ability in these tanks, in these concentrators. So it's usually about 3 liters maximum for continuous. And if it's pulsed, it may go up to about 6 to 9 liters. It runs on batteries or it can be plugged in. And so these things need to be recharged or the batteries need to be changed every so often. Portable liquid concentrator is very similar to the stationary liquid concentrator. Again, very uncommon, needs to be refilled quite often, and many companies don't generally offer this. And then your nasal cannula, and then the tubing. So the nasal cannula are the 2 prongs that go into the nose, which deliver the oxygen. And then the tubing is what's attached to it. And so there's varying lengths of tubing, 25 feet, 50 feet, whatever you need to be able to get that oxygen delivered into your body. All right. So let's kind of switch gears a little bit and talk about other symptoms patients experience when they have interstitial lung disease or pulmonary fibrosis. So chronic breathlessness, the continuous feeling of feeling short of breath. And it's almost universal amongst patients with interstitial lung disease. Everybody experiences it. And then at first, it's kind of, you notice it when you're doing more strenuous activities. Then as the fibrosis may progress, it can be triggered by just daily activities. So doing regular activities of daily living at home. It's one of the strongest determinants of quality of life questionnaires. So when, patients do the pulmonary fibrosis questionnaires, this is the one thing that patients always say that is has the most impact on quality of life, inability to do things because you're feeling so short of breath. So what can we do about it? There are a few things, besides treating the underlying disease to improve this. Pulmonary rehab. So I know it's the other session we'll talk about that in more detail, but pulmonary rehab really helps patients with pulmonary fibrosis, interstitial lung disease feel better, feel like they're not as short of breath. In situations where the fibrosis may continue or progress to points where we don't have many treatment options, there is data to support using opioids, so medications to kind of decrease the breathlessness, decrease the respiratory drive that you'll feel to make you feel better. Seems kind of silly, but a handheld fan that's also been studied as a very low cost intervention that patients may feel better when they have kind of these small fans in front of their face. You're increasing the flow of air that's coming into you, and so it relieves breathlessness. You may feel better by using that. Let's talk a little bit about cough. So cough is also almost, different studies say, quote, different numbers, but it may be universal. About half of patients with ILD, IPF, or pretty much everybody. And it can be multifactorial. So it's related to the lung disease itself, but it also can be related to acid reflux, GERD, allergies, allergic rhinitis, upper airway coughing, nasal congestion, things like that. And then heightened cough receptor sensitivity in patients with lung disease, that definitely occurs. So besides treating the underlying disease and, working on the GERD, working on the allergies, there are other medications we can try to help just stop stimulating cough. So neuromodulators, so things like gabapentin, amitriptyline, baclofen, they're used with varying degrees of success, but some patients may feel much better with that. They're just not coughing all the time. And that dry cough is bothersome. It leads to worsening quality of life. And if you're not coughing, you feel like you're able to do more and go out and not, constantly be bothered by that. And then, if the cough continues, there are other medications we can try. So opioids. So a lot of patients may be using things like Robitussin with codeine. So codeine is a very potent cough suppressor, and we definitely use it for patients who have ILD or IPF because it does work. And then even low dose benzodiazepines. Rarely, it's not too common, but we do use them in situations where the cough is just very significant and has continued to go on even after treating all these other things. And then there are also clinical trials ongoing at Temple. We have the orvipatent trial. So it's a medication specifically for patients with pulmonary fibrosis to decrease the incidence of cough. And so we're excited about it, and we'll see what, the results show of this medication as well. All right, acid reflux. So I spend a lot of my time talking about acid reflux with pretty much every patient I have with interstitial lung disease or pulmonary fibrosis. It's extremely common. Pretty much everybody has symptoms of GERD, even if you don't know it. And it does contribute to coughing very, very commonly. There's differing kind of opinions and data out there about whether it is related to pulmonary fibrosis and it may lead to progression of the interstitial lung disease. But we do our best to control it. It's very possible it may. And so we like to make our patients not have these symptoms and decrease the acidity that you're experiencing. So how do we treat it? So there's a number of things we do. So avoid the main triggering foods. So things like tomatoes, spicy foods, alcohol, chocolate, and mint. So these are kind of the big five that I always talk about, that if you cut these out, then your acid reflux will significantly improve. Sleeping with the head of your bed elevated. So I ask all of my patients to buy a medical wedge pillow. You can buy it on Amazon, Walmart, anywhere, and your head of the bed will be elevated about 30 degrees. And so just by gravity, the acid can't come up, and so it'll have to go down. And so it leads to improvement in nocturnal coughing or nighttime coughing. And then when you wake up, you're not coughing all the time. You have all that acid that's now down instead of coming all the way up into your mouth and then dripping into your lungs. Emptying time. So that's no eating or drinking about 2 hours before lying down. So if you eat dinner or so at 7 and you're done by 8 or whatnot, don't lie down until 10 p.m. Allow that time for the food and drink to be digested and go down into your GI tract instead of sitting in your stomach and then coming back up. Water's okay, but pretty much everything else you try to avoid. Medications to treat acid reflux, so PPI, so that's things like omeprazole or Prilosec, pantoprazole, or Protonix. We use these very commonly. And then H2 blockers, those are things like famotidine, which is Pepcid. And if we think that the acid reflux, is continuing to worsen, we can use both of these medications in conjunction. We often send patients to the GI doctors, the gastroenterologists, who may do endoscopies and see if there's anything else going on to stop this acid reflux from occurring. And then in situations where the acid reflux is really severe and really significant, it's pretty uncommon. It's mostly with patients who have autoimmune diseases or scleroderma. We can send for anti-reflux surgery, so things like Nissen fundoplication, where they surgically tighten that esophagus, which doesn't allow as much acid and stuff to come up, and so that sphincter is tight, and the acid will kind of go down instead of coming up. So lots of different things that we do, and it's commonplace to treat for GERD. So obstructive sleep apnea is also quite common in patients with interstitial lung disease, and it's atypical. It's actually not always necessarily seen in patients with obesity. You may have normal BMI or thin, and you still may have sleep disordered breathing at night. And there's data that show that if you have untreated sleep apnea, it can worsen the lung function over time. So we screen patients with sleep studies, so patients can do them at home. You can, if the fibrosis isn't so severe, then we can definitely do them at home, and then we can see if there's worsening oxygenation overnight, if there's sleep disordered breathing as well, and then treat accordingly with CPAP or BiPAP if necessary. All right. And then kind of the last thing I wanted to touch upon was mental health. And it's having pulmonary fibrosis or interstitial lung disease is a really tough thing to be dealing with. And it's a real disease, and it's a kind of disease entity which you feel breathless, like we talked about. You're feeling short of breath, and what happens is that if the breathing can get worse, or you feel worsening shortness of breath, you start feeling anxious about your breathing. That, why am I short of breath? What's going on? Is it something serious? And that anxiety leads to worsening shortness of breath. And so it's this vicious cycle where you feel anxious, you feel short of breath, and it just goes around and around, and you're not able to do as much. Your activity decreases, the lung function worsens. So it's important to kind of recognize that, up to 50 to 60% of patients with interstitial lung disease or pulmonary fibrosis experience, anxiety, depression, mental health disease because of, what they have to deal with. And so we routinely talk about this. I encourage patients and refer them to mental health professionals, so therapists, psychologists, psychiatrists. And then the role of the palliative care team. So palliative care is not necessarily just end of life care. It's really about symptom management and using them as a resource to help with patients who have symptomatic kind of breathlessness or cough and things like that. And they really focus on on these symptoms instead of treating the underlying disease state, which is what we focus on a lot. And then using medications to help with anxiety and depression. So things like antidepressants, anti-anxiety medication, we use them very commonly and with good success for patients with interstitial lung disease. So that's kind of all I had. So I think we'll have time for some questions in a bit, but thank you all for having me, and talk to you later.
Thank you so much, Dr. Ajmeri. Yet another example of a wealth of information, so we appreciate all of it. Hope you're writing notes. We're going to move into a break time for about 10 minutes. There will be a poll coming through for questions. So please, if you are able to, please feel free to answer away. And so we will have our 10-minute break, maybe get something to eat and relax a little bit. We'll see you in a little bit. Welcome back, everyone. I hope you had a very nice break, able to get a little things done there in 10 minutes. So welcome back. Thank you to everybody who participated in the polls. We'll have those results at the end of our webinar. So thank you for taking the time to do that. We do appreciate that. As Kelsey had mentioned, as you could see in the chat, our upcoming sessions, our pulmonary rehab, Dennis is going to be talking about patient perspective of living with pulmonary fibrosis, ILD, and breakthrough research for ILD with Dr. Criner. What is great about this too, we'll be going into Q&A. We have two Q&As, question and answers. So we'll be heading into that as well. Okay, so I would like to introduce Dr. Pourshahid, talking about pulmonary rehabilitation, and we'll hand that over to Dr. Pourshahid.
Good morning, everyone. I wanted to thank the organizers for this invitation so I can have a brief presentation on the role of pulmonary rehabilitation in interstitial lung diseases. My name is M.Ed Pourshahid, and I'm the Medical Director of Pulmonary Rehabilitation at Temple, Maine University Hospital. I'm a pulmonologist and a critical care physician. So about chronic respiratory diseases, it is a significant burden of disease for globally. It's about 500 million people had chronic respiratory diseases, according to a survey in 2017, around 3.9 million deaths associated with it. These sorts of diseases, they are usually presenting with disabling dyspnea, fatigue, anxiety, depression. It could impair the exercise tolerance and ability for a patient to basically do their daily activities. It reduces the quality of life, and also it contributes to the risk of hospitalization, and it increases the mortality. So this presentation, we're going to be focusing specifically on the interstitial lung disease and pulmonary rehabilitation. So what are interstitial lung disease? Like, I'm just going to be very brief. It was already addressed. There's going to be a diverse group of conditions of lung disease with varying degree of lung inflammation and fibrosis or scarring. It could be specifically idiopathic pulmonary fibrosis is one of the major diseases in these groups, and they are all associated with progressive decline in the lung function, worsening shortness of breath, hypoxemia, and also it is associated with high mortality. Reduction in the exercise capacity is one of the major features of interstitial lung diseases. And the ones who have worse reduction in their exercise capacity, they usually have worse quality of life, and also their survival is also affected. So what is pulmonary rehabilitation? This is a direct quote from a study in 2013, but like comprehensive intervention for patients with chronic respiratory diseases. And this is going to be a specifically tailored to a patient needs from multiple aspects. This includes, but it's not limited to, exercise training, which includes cardio and also resistance training. It has educational part about the nutrition, about their compliance with the medication, the type of disease that they have, some behavioral changes about self-management techniques, specific behavioral techniques, including the breathing techniques, smoking cessation, that's part of the care, and also the behaviors that could positively affect their long-term survival. And it was shown that, and it's basically designed to improve the physical and psychological condition of patients with chronic respiratory diseases. It is shown that it promotes a long-term adherence to health-enhancing behaviors. And this is an essential component of the integrated care for patients with chronic respiratory diseases. So the core components of pulmonary rehabilitation, it is a structured and progressive, individually tailored exercise plan. As I mentioned, it is usually include a cardio component, which includes like aerobic exercises like walking, biking. It depends on the patient's condition, their physical attributes, their access, and the type of rehab that is being offered to them. in addition to some resistance training, because most of these chronic respiratory diseases, they are systemic, and it means that it's not just their lung is affected, it affects their whole body. So it's important that we treat it holistically, looking at the whole body and not just focusing on the lung. They will have some self-management education about how to manage anxiety. Getting short of breath is really a big factor and makes everybody anxious. And the more anxious they are, and the more shallow breath that they take, it's going to make it more difficult for them. So good breathing technique is a big component of it. Patient assessment is an integral part of it, so they are offered the right therapy and the exercise plan that they need during their course. And this is going to help them to build some self-efficacy for them to basically learn what are their needs and how they can address it, how they can be a better active player in their healthcare. And there's going to be multiple outcome measurements, including walk test that it starts with the beginning at the end, that 6-minute walk test, which is a standard measure. And it usually helps for the physicians and for the patient to gauge where the patient is and how they are improving. So let's talk about the benefits of PR, or pulmonary rehabilitation. It's been proven that it reduces the dyspnea or the shortness of breath, the subjective feeling of shortness of breath. It increases the exercise capacity. It improves health-related quality of life, or HRQOL, and emotional function. It improves the social support for these patients. And also for patients with specifically COPD, it shows that it reduces the hospital admissions and readmissions, and also the mortality risk that comes after these hospital admissions. Majority of the studies in the early years were focused on the COPD, but as we are basically progressing, now there is a significant benefit that is recognized for other chronic respiratory diseases, including interstitial lung disease, pulmonary hypertension, asthma, bronchiectasis, CF or non-CF, lung cancer, patients recovering from lung transplant, patients recovering from COVID pneumonia, patients getting ready for some specific advanced procedures like lung volume reduction. So it has multiple different groups that they could potentially benefit from such interventions. So let's talk about specifically about the benefits of pulmonary rehabilitations in patients with interstitial lung diseases. There was a meta-analysis that they pulled 13 randomized clinical trials, or RCTs. It showed improvement in 6-minute walk test, and in comparison to the patients who've been through the PR, or pulmonary rehabilitation, versus the control group. The minimal difference was around 40 meters with a 95% confidence interval from 32 to 47 in the participants, and even the lower end of the confidence interval. And in simple terms, basically that confidence interval is telling us more than 90% chance of this difference, even on the in the lowest amount of predicting how would it affect a population of patients. The minimal amount of difference that it makes, it exceeds the minimal important difference, because sometimes there are some studies that is basically showing that yes, these groups has a slight improvement, but in practical terms, that slight improvement doesn't mean a significant change for the patient. And that's why I'm trying to highlight it, that this difference that it shows in their 6-minute walk test, it is a important difference. It's not just a number slightly higher. They are doing better. That's what it means. And it shows that also their improvement in their 6-minute walk distance, it was maintained after 6 to 12 months follow-up, comparing to the control group, which is fantastic for the patient that we know from the natural course of the disease that they are gradually getting worse in terms of how much they can do. It not only improves their function and how much they can walk, but also it maintains it over 6 to 12 months. And that was a very significant finding. It also shows that the improvement were also evident in other source of measures that we have for the exercise capacity, including peak work, the VO2 peak, which are different ways that we can measure how much a person could exercise. But the 6-minute walk test was the one widely available among all the studies that were available for that randomized clinical trial. So it is not just the walk test, it is showing that overall patients are able to exercise more and they maintain that improvement. The other finding, as we mentioned, health-related quality of life was improved after PR for patients who participated comparing to the control group. They look at the HRQL, the St. George related questionnaire, and the ones that specifically for the IPF were applicable. And it also shows that this minimal difference between these groups were exceeding the minimal important difference. So their quality of life also improves. They are able to exercise more, they feel better, their quality of life improves, and that improvement in the health-related quality of life is also sustained for 6 to 12 months. Another measurement of the dyspnea, or that subjective shortness of breath, and the MMRC scale is one of the ways that we can basically categorize it and put it in objective measurements, and like how much one may be able to exercise. And that was also shown that these patients were able to feel less short of breath when they are exercising comparing to the control group. And that difference was observed and measured both at the end of the rehabilitation and also in a 6 to 12 months follow-up, and that was also maintained. So these were very significant improvements that were all measured for patients with specifically interstitial lung disease who underwent pulmonary rehabilitation. So one may ask is like, okay, yeah, this is all good. What are the adverse events? So among those studies, about like 10 of those randomized clinical trials were actually reporting those specific adverse events, and zero adverse event was reported, which very rarely happens for anyone who is looking at any type of intervention for anyone. The zero adverse events is a significant big deal, because wherever we want to offer an intervention, we are looking at the basically cons and pros, risk versus benefits, and no adverse event. It is making it very difficult to not to offer something like that. Those adverse events that these were reporting were like adverse cardiovascular event, musculoskeletal injuries, or death. There was no significant difference between the control groups or the interventional group in the time that they were followed. Despite its proven benefit, PR is still significantly underused and under-resourced. Even for the COPD, which the evidence of the benefits has been around for more than like 60, 70 years, less than 5% of patients with COPD may actually get the pulmonary rehab that they need, and they need it, but they may only receive it in practical terms. There are multiple barriers for these basically gap that you see, that why there is such an important intervention and why not a lot of people are using it. Part of these issues is the number of the centers that they offer it, the capacity that they have. Sometimes there are longer wait lines, specifically in the rural areas. The challenge that for the patients who actually have to go to a center, the going back and forth, that may be an issue. But one of the significant factors is that the insufficient knowledge that providers and the patients may have in about what is pulmonary rehab, what are the benefits. And when this part is lacking, it doesn't stand a good chance competing with other health and time priorities that a patient might have. So I'm hopeful that this discussion and this clear evidence is going to help for all of us to get a better understanding of what it is and what it can do for patients with interstitial lung diseases. So the most recent practice guideline from American Thoracic Society, published in May 2023, they had these following recommendations for pulmonary rehabilitations for patients with chronic respiratory diseases. There were recommendations for PR with adult patients with COPD, and also after hospitalization for COPD exacerbation. This presentation is specifically focused on ILD, and there was a strong recommendations for PR for adults with interstitial lung disease. There was a conditional recommendations for PR for adults with pulmonary hypertension. That requires a very specific discussion, and that's beyond the scope of this presentation. There was also strong recommendations for offering choice of center-based pulmonary rehab versus tele-rehabilitation, because at this time, as I mentioned, the number of centers that may be able to offer it in person may be limited. There might be a significant wait line, and there is a strong recommendation that each patient should be given a chance when the alternatives are available. And there was a conditional recommendations for offering either supervised maintenance PR or the usual care after they already had a course of pulmonary rehabilitations for patients with COPD. So here are my references, and I'll be happy to answer any questions if at the Q&A. Thank you for your time and attention.
Thank you so much, Dr. Pourshahid. We appreciate this evidence-based presentation of, if you haven't spoken with your pulmonologist about pulmonary rehab, perfect opportunity. So thank you so much for sharing that with us. We truly appreciate your time. Next, we have Dennis. We often talk about how important the patient experience is living with interstitial lung disease. And the voice that comes along with it, because walking in one's shoes, that communicated to your medical team is very, very important. So what we're going to do is just transition over Dr. Criner. And again, make sure you have your ears wide open. It's excellent information and very important information. Without further ado, Dr. Criner.
Hello, and welcome to Clinical Trials for Pulmonary Fibrotic Diseases. My name is Gerard Criner. I'm professor and chair at the Department of Thoracic Medicine and Surgery at the Lewis Katz School of Medicine at Temple University in Philadelphia. The process of pulmonary fibrosis is a relatively complicated one. There is an injury that occurs to the cells that line the lung, called the epithelial cells, and those in the pulmonary blood vessels, called the endothelial cells. With that injury, inflammatory mediators are generated, which then recruit and excite cells that are in the lungs, such as macrophages, T cells, and neutrophils. And once excited, these cells release a variety of chemokines and cytokines, as listed here, that recruit fibroblasts to the lung that proliferate and are activated. And these reside both in the lining of the lung, in the basement membrane of the lung tissue, and also in the muscle cells, the fibroblasts. All of these processes then lead to an excess deposition of scar tissue or fibrotic tissue into the lung tissue itself, which causes the physical and physiologic consequences of patients exhibit with pulmonary fibrosis. Fortunately, over the last decade, patients have been involved in clinical trials that have established effective therapy to slow the rate of decline of lung function in those who have idiopathic pulmonary fibrosis and also some other types of diseases that cause pulmonary fibrosis. To the left is results of the data from 2015 using OFEV or nintedanib, and the patients that received nintedanib had a marked reduction in the rate of FVC, a measure of lung function, compared to the patients that were not on that therapy. Similarly, patients in another study who were placed on pirfenidone or Esbriet had a similar reduction in the rate of decline in lung function compared to patients that were on placebo therapy. These two therapies have been the cornerstone of treatment of patients with pulmonary fibrosis over the last decade or so. Now, there's some benefits to both of these therapies. They reduce disease progression significantly with either of these agents in a comparable quantitative degree. Both of these drugs decrease the risk of acute flare-ups of the disease, called acute exacerbations, and decrease the need for hospitalization due to pulmonary fibrosis. And in pooled analysis of patients that have received either of these two drugs, there is a signal for improved survival. However, both of these drugs have limitation. Both of them reduce progression partially, not fully. They do not reverse the fibrosis that exists into the lung. Patients often don't feel better. They still complain of cough. They're short of breath at unacceptably high rates. There are side effects related to the drugs, which include nausea, vomiting, diarrhea, weight loss, headache, skin rash, and in patients, some complain of fatigue. The mortality of these diseases that cause lung scarring is still unacceptably high, and both of these drugs are fairly expensive. Because of the benefits and also the limitations, there's a great need for other drugs that can be added on to these therapies, or instead of these therapies, may be beneficial to decrease lung scarring that occurs in patients with pulmonary fibrosis in a hope to reverse the process, totally cease the process, and make patients feel better from standpoint of shortness of breath and cough. This is an example of one study recently published and currently ongoing in the United States of a trial of a new drug called phosphodiesterase 4B inhibitor. And this drug showed 2 years ago that in patients that received it in a red compared to those who did not in a placebo, there was significant halt of the progression of fibrotic lung disease as measured by a reduction in forced vital capacity. It's a spirometric value. And what they showed in this study is that if the patients received this drug compared to placebo and patients weren't on any other drug, there was significant reduction in the progression of the disease. But more importantly, it showed in patients who are already on Ofev or Esbriet, the established medications, that the addition of this new compound further reduced the rate of lung progression. It was a short-term study over 3 months. There's now an international study, which Temple and other centers have participated in, that have looked at this in a much longer study with a much greater number of patients. That study currently is in progress, but results of this study should be available, we believe, early next fall. Now, there's been an improvement in techniques of how we search for new drugs that may be available. This is an example which one drug company, AstraZeneca, has done, where they basically have developed in vitro models of human alveoli called organoids. And these are three-dimensional cell cultures that replicate what's happening in the lung and have many other advantages to other models that were just in a one dimension, a monoculture. And when you have a three-dimension organoid, you can then use artificial intelligence and machine learning to develop and take drugs and pathways that are currently in process to further study genes, proteins, and compounds to see if there's new targets that can be used to control lung fibrosis in patients. And as you can see, there is many different pathways that we talked about, and cells and compounds that are generated in the process of fibrosis. And the use of these forms of technology have now allowed us, shown here in the blue, to develop new drugs for various targets in this complicated pathway of causing lung fibrosis that may be beneficial either solely or in aggregate with other compounds to be able to stem the rate of progression or even reverse it, and more importantly, improve patients' symptoms and improve their survival. Well, at Temple, currently we have 16 ongoing trials. There's about 2 new trials that we have per month because of this rapidly evolving process as shown here that can treat patients with idiopathic pulmonary fibrosis or other forms of progressing fibrosing alveolitis such as scleroderma, that these drugs can be taken either orally in addition to the drugs that are already clinically available, sometimes subcutaneously with a shot under the skin like what patients use for insulin, or some agents are going to be provided in the inhaled route. All of these studies are being done to try to improve the condition of patients with pulmonary fibrosis, and is the only way with patient involvement that we can develop new therapies for patients with this important and in some cases morbid and mortal disease. If you're interested in learning more about any of these studies, then you can either call us at the numbers provided here or email us at the number shown here, and we'll be happy to give you more information. Once again, thanks very much for your attention, If there's any questions that you may have, you can contact me at the numbers and emails provided below. Have a good day.
Thank you so much, Dr. Criner. Again, as you can see how valuable and how important clinical trials are. If you're interested in a clinical trial, ILD clinical trial, you'll see the contact information here on your left. And we will be able to share this. The webinar is recorded, so you'll be able to see this. If you need any information post webinar, you just let us know, we'll get that to you. Let's do this. What we're going to do is we're going to transition, as we do living with ILD. We pivot and adjust, and we make things work, right? And so that's exactly what happened here. And I just have such a pleasure to introduce you our friend Dennis. We've worked with Dennis for many years and asked Dennis to join us because, as I mentioned before, how important the person voice is in living with ILD. And so it is always such an honor to introduce you, Dennis. I'm going to hand it over to you. And if you want to get started, I could start with questions, however you want to move forward. It's all you.
Okay, Jen, thanks. I'll just tell a brief story of my journey. My name's Denny Hood, as Jen said. I'm 77 years old, and my journey began back in April 2017. I'd had a chest cold and it didn't seem to want to go away, so I went up going to my doctor, and he gave me some inhalers, and they really didn't work. So he said, well, let's get a chest x-ray and see what's really going on. And about 3 days later, I got a call to come into the office and see my doctor. And at that time, he gave me the news that I had pulmonary fibrosis, as seen on the chest x-ray. And subsequently, I had a CAT scan, which confirmed that fact. I really didn't know anything about pulmonary fibrosis. I figured, well, give me the pill and I'll take it and everything will be okay. But it didn't work out that way. He says, you really need to go see a good pulmonologist. And so he recommended a couple of doctors, and I was able to get an appointment with one of the doctors at one of the larger hospitals in the Philadelphia area. And I went down there with my wife, Nancy, my wife of 54 years. And we meet with the doctor, and then it was a very bad experience for me, for both of us, really. She's explaining the nuances of pulmonary fibrosis. And I said, well, what's the prognosis? And she says, well, most people who have this disease die within 3 to 5 years, which really shocked me. And I says, well, how about medicines? Isn't there any medicines that I could take to mitigate the situation? She said, well, the truth of the matter is a lot of people who take the medicines feel it's as bad as the disease itself. And so we talked a little bit more, and I made an appointment to see her in 2 more months, and went on home and started talking to my family and made them aware of what was going on. As luck would have it, I had an appointment to see my cardiologist within a week. I went in there, and I've known the cardiologist for 20 years. He's a good friend. And he said, if I was you, I'd get a second opinion. In fact, I would go see Dr. Criner down at Temple Hospital. And through his help, I was able to make an appointment rather quickly. And so I went down to see Dr. Criner. And the situation was totally different. Dr. Criner was very optimistic with me. He said, this doctor you saw should have never told me that. Everybody has a different beginning. Everybody has a different body with different nuances. And I wouldn't give you an estimate of how long you're going to live. He says, you take it one step at a time. We have medicines that slow the progression by 50%. We have clinical studies that go on all the time, and some of them they seem promising. And so with that, he gave me a stack of 6 clinical studies that he wanted me to take a look at and see if I thought they would have any value for me. And I took those home. At the same time, he says, I'm going to put you on OFEV, and you'll be getting that in a short time, and then we'll go from there. And from that day on, not that day on, about 6 weeks later, I started the OFEV. And went down to Temple about every 2 to 3 months, and I had the pulmonary function test. I had the 6-minute walk. I would meet with the nurse practitioners. I would meet with Dr. Criner, and we kind of tracked how I was doing. And in truth, my disease was slowly progressing, which I was tickled about. When you do the pulmonary function test and the 6-minute walk, it gives them a barometer to see how well you're really doing. One of the things that Dr. Criner emphasized to me that exercise was very important. And I was already exercising. My background, I'm retired from the Air Force. So I go to the gym 4 or 5 times a week anyway, and I do at least a half hour of cardio. And with that, I would just go down there every 2 or 3 months. And so fast forward, it's now 2020, and I get a call from my brother, my older brother, by 3 years. And he informs me that he was just diagnosed with pulmonary fibrosis, which was really shocking to me. It probably shouldn't have been, only because I had it. And my father died with a lung problem when he was 61 years old. And only about a year ago, I found out he actually had pulmonary fibrosis. So the 3 of us had pulmonary fibrosis. I was able to make an appointment for my brother to see Dr. Criner, and he started the same journey I was on, the same process of going down every 3 or 4 months. Only we learned rather quickly that he had a much more aggressive disease. Within a year, he was on oxygen. Deteriorating, I thought, rather quickly. I would go down with him to all his appointments because he was always nervous. He never asked the right questions. And so we went down there together. And it was actually a great experience in some ways. Within 2 years, he was on not only a home concentrator, but he needed 2 home concentrators. So at this point, we decided it might be appropriate for him to try to get listed for a lung transplant. But unfortunately, after going through all the testing, it was determined that he was not going to be a good candidate for lung transplant for several reasons. He was 79 years old at that point. He had some calcification in his arteries, and he had a blockage in one of them. So it was decided that he was not going to be a candidate. And last March 2023, my brother passed away. A sad day for us, for sure. But moving forward, in February of 2023, they came out with a new clinical medicine under the name of Fibronir. And I'd heard about it months before that. And so I told the research people, when it actually becomes available, please include me. And it turned out I was the first person at Temple to start the Fibronir clinical study. Fibronir study is a phase 3 study. It's a double-blind study. And with that, you get a 1/3 chance, a 30% chance of getting the medicine. You get another 30% chance of getting half the medicine. And there's another 30% chance of getting the placebo. Since I've been on that, things have changed for me. Within 6 weeks, I felt a change. My shortness of breath improved. I continued to go to the gym. And when I go to the gym, I always bring a pulse ox with me, so I know exactly where I stand as far as my oxygen level. And I saw improvement there. Prior to taking the medicine, I was probably down to about 92, 93 on the pulse ox. After taking the medicine, it improved to up to 95, 96 sometimes. And so dramatic change. And then the other thing that changed was I was getting diarrhea for the first time in 6.5 years. And so I have my own system for dealing with that. I take a Metamucil, and that's, whatever reason, that helps me to manage the diarrhea. So in my little world, in my little head, I decided I must be on the medicine, and it must be working for me. And so I started that process. I would get down to Temple every 5 weeks, and I would meet with Dr. Ajmeri. I would have a lot of testing done, spirometry, a lot of blood taking. At one point, one session, they took 24 vials of blood. They would take, what's the word I'm looking for? Besides spirometry, they would go through a battery of tests using an iPad and asking a lot of questions. And so 12 months have gone by. It's now February 2024. And for me, really the study is over. I continue to take the medicine, But the study is a worldwide study, and there's actually 965 patients who have pulmonary fibrosis who are in this study. And hopefully, if things go to plan, that should wrap up in August of this year. And we're anxious for that to get through the process. Hopefully, it shows the results they're looking for, and then they will get the FDA approval. So I believe that this is the medicine that's going to take care of me, and it's going to stop the scarring that's going on in my lungs. And my body's telling me that that's in fact happening. And phase 2 of this study, that's what happened with the people on the full medicine. The scarring stopped. So I'm very optimistic. A couple of things I'll point out to you. I had heard about genetic testing, and back when I was looking into it, I went down to Johns Hopkins University with my 3 sisters and met with a genetic counselor who was very, very helpful. And as it turned out, they did not find the gene be linked to pulmonary fibrosis, which in a way was good news. One of the last things I want to share with you is I go down to Florida, at least I try to every winter for anywhere from 1 to 2 months. And this year I was down there, and my 3 sisters were down there. And we're talking about the loss of my brother, and talking about the fact that why is it that we have this disease? And we came to a conclusion. And it was ironic. My father was a city fireman in Philadelphia. He also worked in the shipyard. And he said he was around asbestos a lot. And I believe that's why he died. He had IPF because of the asbestos. My brother and I come from a family of 6 children and 2 parents. We lived in a small row house in Philadelphia, and my parents didn't have a lot, and so my mother became pregnant when I was 12 years old, and so this was the 6th child. And so my father fixed up our basement, and that became my brother's bedroom and my bedroom. And we lived there in that basement for 10 years. But I've since found out that, I'm sorry, another phone came in. I just have found out that when he fixed up the basement, they used ceiling panels that are made of asbestos. And so for 10 years, I was with my brother in this setting, and I'm convinced that's where our pulmonary fibrosis has come from. So let me finally say, it's been a crazy journey, a very different journey from a lot of other people, but there's been 3 women in my life that I need to mention very quickly. One is my wife. She's been terrific. She's been with me every step of the way. Like I mentioned earlier, we've been married for 54 years, and I certainly could not have done this without her. The second woman is my youngest sister. She's a spiritual person. I was born a Catholic. I was raised a Catholic, but I wasn't a great Catholic. I was a Catholic. It's more like almost an autopilot or cruise control. And then she came into my life in a wonderful way, helped me rearrange my priorities, and now my faith and my relationship with God has become a very big deal to me. And it just helps me so much emotionally. I go to Mass every day, and my faith is a big, big part of my life. And then the last person I want to mention is the person I'm looking at right now, and that's Jen Wescoe. Jen, I met her 7 years at the beginning of this process. We used to meet quarterly down at Temple Hospital. We'd be in this conference room, and we'd have presenters, and it was a nice social thing. It helped you meet the other patients. And that's a good thing, because everybody's on a different step, milestone in their journey. And that was very educational for me. But COVID came around, and these meetings went away, and Jen brought us together by virtue of these Zoom meetings we have. And they're wonderful. They're wonderful. They bring in the experts. They educate us. We get a little smarter. When you get a little smarter, it tends to help you emotionally, besides physically. And so she's been wonderful. She's very humble, and but I appreciate her so much. So that's the end of my story. Thank you.
Oh, Dennis, thank you. Thank you for spending time with us this morning. Thank you for sharing your story, your honest experiences. We know that every experience is uniquely our own. you inspire us, you educate us, and you're supportive of others through this whole process. And, you know, it's a true honor, as we'll talk about later too, about being in, you know, in our community is very, very connected and learning so much from each other and moving forward together. And that's our support network. So Dennis, thank you so much for sharing your story with us. And as we know how important a person's experiences can help so many others. So thank you so much, Dennis.
Thank you, Jen.
Absolutely. Oh. Okay, so now what we're going to do is we're going to move into Q&A. So this is a very important part of this whole process, is ask these questions that are coming to you during the webinar or that you have already prepared. And yes, we'll be able to get a copy. This is all recorded for you, Susan. And so we'll open it up to everyone. We have Eileen Holland with us. We have Dr. Pourshahid with us. Ask away. The first question is from Mercy. How is ILD different from COPD? Excellent question. So I think Eileen is probably there.
Sorry, I'm here.
There you are. Yep.
So, completely different disease type. Interstitial lung disease is more of a restrictive lung disease. It makes the lung smaller because of the scarring. And COPD is more of an obstructive lung disease associated with smoke exposure or smoke inhalation.
Excellent, Eileen. Thank you.
Sure.
That question comes up often.
You can, however, have mixed disease. You can have, you know, like a COPD with emphysema, and then also have something called CPFE, which is combined pulmonary fibrosis with emphysema, and have some scarring at the bases. So it's not completely separate. Sometimes it's conjoined.
Right. Eileen, thank you.
Sure.
Anybody else have a question? This is a wonderful opportunity. Okay, great. So what are exercises recommended?
In terms of like pulmonary rehab or something you can do on your own? Question.
I think maybe balance the two if, you know, if it's helpful that way in regular life, pulmonary rehab, because that's pretty over.
I mean, pulmonary rehab, we always recommend first because it's monitored by a respiratory therapist. You're in, you know, a close setting, your oxygen, your heart rate, all of that's being monitored. But sometimes there's patients that have used up their lifetime allotment. So you're only allowed 90 sessions per lifetime. So I don't know, honestly, how some patients get, you know, they get ongoing therapy, like as a maintenance. I don't know who covers, but it's always good to ask your pulmonary rehab, you know, specific to that area, if they can join maintenance. But like any day-to-day activity, like walking outside, walking in the mall, because it's climate controlled for the, you know, the winter time. It's also climate controlled for the summertime if it's too hot. There's nothing wrong with walking outside at all, at your own pace with your oxygen as needed. You know, any kind of arm bike so you can build up arm strength. Leg therapy, you can also do, we recommend, if you can't get to a therapy session like a pulmonary rehab, we do virtual pulmonary rehab, which they contact you, you get on a link, and a lot of patients really love it because they can do it in the comfort of their own home.
Excellent. Thank you, Eileen.
Sure.
These are great questions, you know, because it's really daily life type of managing.
Right.
Are wet coughs and wheezing typical for ILD, and how can you be sure?
So wet cough, I mean, every patient is different. I mean, I would say most of the time with ILD it's a dry cough. But like I said, you can also have combined pulmonary fibrosis with emphysema, and then you can have a bronchitic phenotype, whereas that would constitute like a wet or a productive cough. Generally, we can find, we can find that out on a CAT scan if a patient has like dilated airway walls consistent with chronic bronchitis. You can have, sometimes patients have asthma with ILD. They're born with asthma, so they may have like a bronchitic asthma phenotype. So it's kind of patient specific. We'd have to like kind of further evaluate for that.
Mm-hmm. Mm-hmm. Yeah, because you often hear the dry cough, hacking cough, and you do hear about the wet cough, definitely from folks.
Right.
So good. That was a great question.
Yeah.
Another question is, what if someone needs to get a second opinion? What type of process would you know that they would need to do?
So if they're a patient from the outside and they want to
Yeah.
come to Temple, so they just would call the 1-800-TEMPLE-MED number, and they could be set up with anybody, any of the physicians that specialize in interstitial lung disease, like, Dr. Rachel Criner, Dr. Gerard Criner, Dr. Ajmeri, any of the physicians that focus on interstitial lung disease. And then, we also have our CAM referral team with Heather. And I don't know specifically how it's, routed to them, but they are hugely a part of our team in getting patients in. Taronda, Dr. Criner's assistant, she gets patients in. So they really only have to provide their insurance information and when they're available. They could come to different sites like Temple, Maine, Temple at Oaks, Temple at Chestnut Hill, and Temple, did I say Chestnut Hill? Jeans is the other one. Yeah. But
Excellent.
specific doctors go to specific satellite offices. So not
Okay.
everybody goes to each satellite office.
Okay.
Yeah.
Okay, excellent. This question is does one climate better than the other to live in while managing ILD?
Not necessarily, because every patient is specific. So and is unique. So some patients may feel better in the hotter weather. So they we have snowbirds. They go to Florida in the winter, and then they come back here to Jersey or PA or Delaware in the summertime because it's too hot in Florida. So, I mean, it really is patient specific, because sometimes patients say the cold hurts their chest. So there's no better climate, not per se. So it's all, patient specific, symptom specific.
Yeah, you have definitely people traveling during the winter. If someone is on OFEV, and I'm assuming it's the Fibroneer study, or no, I can't say that. All right, let me back up. So we have someone who's on OFEV. Can one enter a trial, or would that person need to discontinue the OFEV during the trial?
So that's actually a really good question. The Fibroneer trial is closed right now for enrollment, but we do have other clinical trials for IPF and ILD, chronic fibrosing ILD. So Rachel and some of the other coordinators would be able to answer that better than I would. But usually there is a period where you'd have to be stabilized on the drug for like 6 to 8 weeks prior to enrollment. So like if you're having issues with side effects such as diarrhea, you may have to, not enroll until you're stable on a stable dose of every day or twice a day. But they would be able to answer that better for you. So I don't want to misspeak.
Right. Understood.
This is Denny talking. I just want you to know, I think I agree with Eileen, and that is some of the studies you can be on the OFEV, like the Fibroneer, you could stay on and there's others where you're not allowed to. So it's going to vary.
Yeah.
Great. Thank you, Denny. So what we're going to do is we have another Q&A. So what we're going to do is wrap this up and the Q&A portion of it, and we're going to transition into our lung transplant. And I believe Kevin's here to have and educate us about lung transplantation. So maybe some of the folks have some questions in the Q&A that maybe can be answered from Kevin. Great. All right, Kevin.
Hello, everybody. Thank you for taking the time to participate in the ILD webinar. My name is Kevin Carney from Temple Hospital. I'm going to talk about lung transplant specific to the patients with interstitial lung disease. So for purposes of this slide, I just want to focus on a few key points. So the first human lung transplant was done in 1963. And unfortunately, that patient only survived about 18 days before he died from infection and airway complications. And then from 1963 to 1983, there were another 44 attempts at a human-to-human lung transplant. Unfortunately, most patients only survived a number of weeks, and no patient survived more than a year. Probably the key point in 1983, a medication called cyclosporin was developed, studied, and approved for organ transplantation. And then in November of 1983, Dr. Cooper at Toronto at the time did a single lung transplant for a patient with interstitial lung disease, and he survived for 7 years. So from less than a month to 7 years, and that's kind of really when the beginning of lung transplant started. So from very humble beginnings in the early 80s to approximately 4,500 to 5,000 lung transplants being done around the world. You can see that the majority of transplants done around the world are bilateral lung transplants. Here in the United States, it's a little bit more challenging, especially in our part of the country, in the Northeast, where there are so many patients and so many transplant centers. We don't have enough lungs to go around. So our philosophy is to try and help as many patients as we can. So you can see around 2005 is when lung transplant kind of really took off. And one of those reasons is the introduction of the lung allocation score here in the United States and used in some countries, not all. But this lung allocation score really took into consideration the severity of one's disease, the likelihood of them surviving without a transplant, and together that lung allocation score was formed. So before 2005, time on the list meant everything. And on average, patients waited about 2 to 2.5 years before a transplant became available. Unfortunately, for patients with interstitial lung disease, they often didn't have 2 to 2.5 years time to wait. So in May of 2005, the allocation score was comprised, and you can see in this area in white the significant growth in the number of transplants for patients with interstitial lung disease. So now around the world, it accounts for about 30 to 35% of patients. Here at Temple, we do about 65 to 70% of our patients that have interstitial lung disease. It's also important to realize that size is important. Whether we're assembling a car or a plane or doing lung transplant or bariatric surgery, the more experience a center has, the better the outcomes, and that's shown in a number of studies. So just for the audience's information, you can see the median to average size lung transplant program does around 20 to 30 transplants per year. We know that if you are transplanted at a center that does 40 or more cases per year, you have a survival advantage. And you can see there's a small number, about 20 centers around the world, and this was as of 2019. At that time, 20 centers around the world accounted for 40% of all lung transplants done around the world. Here at Temple, you can see over the last 5 years, we've averaged about 130 transplants per year. So well above that 40 per year point that suggests a survival advantage. And that number is more than 80 compared to our Duke, the number 2 center in the United States by volume. Next, I wanted to talk about survival and how that's changed over the years. You can see during that first cohort, 1992 to 2001, you can see patient median survival was just under 5 years at 4.7 years. If you survive for that first year, patients survived on average about 7.5 years from the time of transplant. So when I first started doing transplant in the early 2000s, we were quoting a 1-year survival about 75%. We had improvement from 2002 to 2009, where survival improved by almost 2 years to 6.5 years. And we were talking about survival about 80 to 85%. And now with the current data, most high quality centers have survival 88 to 90% or more. And you can see here at Temple, we actually exceeded 91%, which is not only higher than the national average of about 88%, but also higher than our expected survival because we often transplant patients that other centers wouldn't consider. So next I want to talk about referral for evaluation. And the important thing to know is that a referral for transplant doesn't mean that now is the time to get placed on a waiting list. Often patients are referred, in my opinion, late to transplant. So when we're seeing them, they're sick enough to be actively listed for transplant. But I want to clarify that when patients are referred for transplant, ideally, we do that evaluation because the evaluation is very time consuming. It takes several weeks, or if not longer. The evaluation is very thorough. It's time consuming. Ideally, we establish whether transplant is an option for this patient or not. And then once that patient's clinical condition deteriorates to a point where we feel lung transplant is needed, at that time, patients are listed for transplant. And I think that's very important for patients with interstitial lung disease. So for patients in the audience that have either a biopsy or a CAT scan suggestive of UIP or fibrosing NSIP, regardless of their need for oxygen or their forced vital capacity, guidelines suggest patients with these diagnoses should be evaluated for transplant. Again, evaluation and listing are two separate decisions. For a small number of patients with an inflammatory interstitial lung disease like hypersensitivity pneumonitis, I think it's prudent to see if patients benefit with the use of prednisone plus or minus medicines like mycophenolate. And if we're seeing radiographic and clinical improvement and improvement in pulmonary function tests, that could perhaps delay the need for transplant. And in a small number of patients, the decision for transplant is stopped. So I think it's important for the audience to realize when they should be evaluated for lung transplant. So when we talk about some of the reasons why we can't consider all patients for transplant, realize we're allocating a very scarce resource. There's just not enough lungs to go around. So societies have created some guidelines to offer programs some insight as to the types of conditions that patients have that may not be a candidate for transplant. So we talk about recent history of malignancy, realize patients are on immunosuppressive medications. For skin cancer, aside from melanoma, that wouldn't meet that criteria. Prostate cancer has become more liberal over the years. But as a general rule, if you have a condition aside from skin cancer, there could be 2, 3, 4 years of cancer-free survival, depending on the center. if patients ideally patients listed for transplant should have, end-stage respiratory disease without any other organ involvements, i.e. the kidneys, the heart, or the liver, unless a combined organ transplant can be performed. And that number is very, very small. Less than 5% of all lung transplants are a combined procedure. Heart and lung transplant being the most common, but we're still doing probably between 1% and 2% of our cases per year are combined organ transplant here at Temple. We realize that because we're allocating a scarce resource, we can't consider this for patients with, instability. Their blood pressure can't be supported without numerous medications. They have an overwhelming infection. And then for patients that have significant obesity, we know that obesity itself is a pro-inflammatory state. It can affect rehab after transplant. So we try and get patients to a BMI ideally close to 32 or less. Some other things that we need to consider is if patients haven't been adherent to their medical therapy. They're not using oxygen, they're not using their medications, they're not doing their blood work, they've missed medical appointments. That suggests that if they were to be transplanted, that type of behavior may continue. And again, we're allocating a scarce resource. We need to be very, very careful when we're allocating these to patients. We want to make sure patients can care for this very generous gift. For some patients that have untreated psychological conditions or cognitive conditions that we don't think they'd be able to care for themselves, that would be an exclusion. We always need a good support person, ideally two. We want to make sure people are in as physically good a shape as they can. And we want to make sure that they're not continuing to smoke or using illicit drugs or overusing alcohol. So next we'll talk about the type of procedures that patients can undergo. One is a single lung transplant. And again, at Temple, about 70% of our patients undergo a single lung transplant. Why? Because it's a more efficient use of a very limited donor supply. We know that even patients who are evaluated, listed for transplant, about 10 to 15% of those patients won't survive until a transplant becomes available to them. So we want to try and use a very scarce resource as efficiently as possible and consider single lung transplant as often as we can. It's more technologically straightforward. It's removal of one lung and the implantation of the other lung. So it's a shorter anesthesia time, a shorter operation, therefore a shorter intensive care unit stay. The caveat is for a small number of patients that have pulmonary hypertension, that single lung transplant receives a lot of that cardiac output. So for a number of patients that have pulmonary hypertension, either primarily or secondarily, that burden may be too significant. So that's what we decide during the evaluation. And lastly, that if we do a single lung, that means the other lung remains. So there's a risk for pneumothorax, a very small risk for lung cancer in the old lung, a concern for exacerbation of COPD or interstitial lung disease is there, and also for potential infection. There are some patients that we would have to do a bilateral lung transplant, and those are for patients that have diseases like cystic fibrosis, where they have very severe bullous emphysema that have had recurrent pneumothoraces. We do know that in time, patients will have a functional advantage, and over time, not immediately in those first 30 days, there's a survival advantage. So again, we want to try and help as many patients as we can, but realize that some patients, only a double lung transplant is an option for them. When we talk about different surgical techniques for a single lung transplant, there are two procedures called a lateral thoracotomy. Some people also use what's called a muscle-sparing thoracotomy. This used to be the procedure of choice, aside from the median sternotomy, because of sternal dehiscence and sternal infections. But for patients, it was very painful, had a lot of chronic pain after the procedure. So a clamshell or a transverse thoracotomy incision was developed. And Dr. Toyota, one of our surgeons here at Temple, was very instrumental in that surgical advancement, where not only do the surgeons have better access to the chest wall, but it's a much less painful procedure for patients. So in the past, the majority of patients would be discharged from the hospital requiring narcotics for that lateral or muscle-sparing thoracotomy. Here at Temple, the minority of patients require narcotics at time of discharge. So we've made great progress. For some patients that require both a lung transplant and maybe a valve replacement or a bypass procedure, median sternotomy is often a treatment of choice just for placement of bypass and for better access of the heart. But this is a smaller number of patients. So by and large, that transverse thoracotomy is the procedure that we see here every day. Lastly, I wanted to talk about survival with and without a transplant. So earlier we talked about 1-year survival nationally, about 88%. Here at Temple, about 91 to 92%. And you can see this is for a program in Australia. And you can see here are patients who had a transplant, and you can see their median survival was well over about 8 years. Conversely, these were patients who at the time of this study were still listed for transplant. And you can see that their median survival was around a year to about a year and a half. And you can see in this statistic here, hazard ratio of 0.15. So as I explain this, simply by being transplanted gives you about a 7, nearly 8 times survival advantage than if you haven't been transplanted yet. So the philosophy here at Temple and in a number of programs around the world is, how can we transplant as many people as we can to really, really improve their survival advantage? And that's why we believe in that single lung transplant. Lastly, I want to talk about quality of life after lung transplant. And you can see that for the majority of patients who undergo a lung transplant, their physical health and functioning, their energy and overall well-being is increased. And we know that the early involvement in pulmonary rehabilitation, ideally at the time of transplant and then shortly after transplant, really, really improves one's quality of life. So we're a big proponent for pulmonary rehabilitation, not just for patients pursuing lung transplant, but for all patients with significant lung disease. Thank you, everybody, for attending this presentation. I'll be participating in a question and answer session around 12:15. Thank you.
Thank you so much, Kevin. We look forward to seeing you very, very soon. We have talked about so many things with the journey living with ILD, and we had talked about before how important supportive care, support groups are. And so I'm going to be bringing up my slides for our presentation with Michelle. And it's really just always such an honor to work with Michelle and making sure patients and families, and Eileen is with the
What is it about? Oh, support groups.
Oh, Michelle, are you there?
I am. I'm trying.
Okay.
To,
Okay.
I think Eileen's on.
Okay, good. All right. So what we're going to be talking about now at this point for the your medical care team supporting you along the way. The next step is the journey ahead, looking forward to supportive care through support groups and resources. So as I talked about, this is a very integral part in your journey in navigating ILD, pulmonary fibrosis. And so when we think about this, and when you are initially diagnosed, you think about, okay, what's next? Or very overwhelming, very isolating, and how did this happen? And we're going to be talking in the next slide about cycle of acceptance. And so we take that moment and we think about it. How am I feeling physically? So we're, depending on where you're diagnosed with the progression of ILD, how am I feeling physically? Breathlessness, or I'm feeling okay. And emotionally, just how I talked about, this is a bit of emotional roller coaster. Research shows that if you have more of depressive type symptoms prior to diagnosis with ILD or chronic illness, you want to make sure you manage that in a way that bringing in supportive care along the way is so important. And then we think about what's next. So we're at this point here. And so how do I get this information? Support groups, supportive care, education, resources. And so this is very, very valuable in moving forward in your journey ahead. So I talked about very briefly about the cycle of acceptance. So we go through this whole process of managing what we are feeling. And we go through the initial diagnosis initially and thinking, okay, I'm going through this. I just heard this, and I'm going to go to Dr. Google. And we want to make sure we are going to vetted resources for your information. So you can go through a point in this cycle of acceptance, of shock and denial. This can't be true, of understanding when you talk with your experts about ILD. I can't believe it. Why did this happen? And then you can go and move into, this is an ebb and flow. This is not linear. This is an ebb and flow. You can go around this in a progressive way, and how uniquely it is you are managing this emotionally. And then you can move into a state of intense worry, or more of a balanced worry, fear, isolation, anger, anxiety. And this type of feelings are, why me? Why is this happening to me? And how can I manage this with my family? How can we keep doing this, right? And so the lot of emotional, like I said, emotional roller coaster, ebb and flow certainly can be in place. And then we start bargaining. If I make sure that I go to church every Sunday, or I go and I make sure that I'm talking with my pulmonologist a lot, and and maybe he'll make it better, or she'll make it better. How do we do this? So there's a lot of bargaining that happens. Then we can move into, it depends how you are in the process of depression. You think about your past losses, is your job, your family, your friends, and then looking into future losses of what am I going to be missing while navigating ILD, and how am I going to manage all of this? And then we get into the acceptance phase, and notice its cycle of acceptance. This is such a process, and understanding and acknowledging that with yourself, that this is something that is uniquely yours. And so through, when we get to acceptance, and we work hard to get there, not everybody does. In all fairness, not everybody does. It's a lot of work. And so, what does it mean to you? You're learning ways of managing and coping and living with ILD, hence support groups. Get your education, get your support. how to empower yourself, how to advocate for yourself. Talk with your pulmonologist, talk with your respiratory therapist and pulmonary rehab, and learning to, you're not going to fix everything, right? You're going to do the best that you can. You're going to compartmentalize and live each day the best way you possibly can. There is no guidebook. You just have to do the best you can. It's not that simple, but it's that basic is just, there are no expectations. Just do the best you can. So to understand the cycle of acceptance, you acknowledge how you're feeling and what's going on, and you give it a name. Now we get to supportive care and getting connected. Why do we have support groups? Why are they so important? Well, we have an opportunity to learn. We understand interstitial lung disease, pulmonary fibrosis, and what you're managing. So you're educated when you're talking with your pulmonologist. And then as you are in the support groups, you get a sense of feeling comfortable. The interactions we have in our support groups are very powerful. We are so appreciative of folks that are sharing their story, but through that story too, we learn a lot from that. So we could take that home in our daily life. It's safe. There's a trusting environment. So, and there's another emotional, practical support of coping with your anxiety, perhaps depression. How are you managing your family dynamics? They do shift of what's happening, of living with ILD and feeling overwhelmed, one step at a time. And how are you building your relationships with other people living with ILD in these support groups? We talk about care partners. This is synonymous with caregivers. We see this as a partnership. This is not an isolated movement forward. You are surrounded by people who support you along the way. And we call that a wraparound approach, and how really vital that is in moving forward. You do not need to do this alone. And you talk openly and honestly with each other. This is a social outlet, as well as how your grandkids doing. So it's very fulfilling that way. And then you really gather a wealth of information, that is for sure. We just talked about clinical trials, what's happening in current research. We talked about pulmonary rehab. And so this is very, very important in this transition forward and this movement forward for you and for empowering yourself and advocating for yourself. So as time goes on through the years, we're really learning of really what's working with folks we're working with and not working. What are the challenges? What can we do, and what are we doing that's helpful? And so what we brought apart point really is the edutherapeutic model. And so what we found was in integrating the educational component of our support groups and the therapeutic approach in our support groups, and combining that together really gives a holistic, fulfilling way for our folks that we work with every day. Patients, care partners, family members are all included in our support group. So this is a model that we're really making sure we implement, we find it successful, and would love that for other types of supportive care. It's very important. And bringing in healthcare professionals, clinicians, other patient advocacy organizations, our researchers. And what we also found was within the open forum format is how the conversation starts. Very active, very integrative, interactive, dynamic conversation where we learn a lot from each other. And also you're learning through the virtual platforms are using whiteboards, polls, breakout rooms, and how is that beneficial? We need to do more of that. Noted. Is there anything, Michelle, that you would like to add? I'm going on and on. Michelle, do you want to add anything?
No, Jen, you're doing a great job.
there's a question here in the chat about how to join support groups. And I think that sometimes we don't realize that some patients, they feel intimidated by the support groups and like going to learn. But what I've learned throughout the years and when we had the support groups lives is that patients actually all come in different stages and they all have something to learn from each other. So I think that if you're hesitant and thinking that maybe you don't want or feel like you can be part of a support group, you know, giving it a try. And like Jen talked about, you know, research trials, you know, they're opening up every day. It's a place where you can go learn what's new that, you know, with IPF or interstitial lung disease. And again, just as you learn from us, we are learning from the patients. And I think it's a great positive learning environment. There's many support groups. If I'm going off, let me know. Many support groups, and we have them here. But Jen's, I know somebody just put, how can I join a support group? What I think is great is that Jen has opened so many support groups or started throughout the tri-state area. So if you're unable due to some of your symptoms or distance, you know, there's many virtual support group, and Jen is a great resource for that. So definitely touching base with Jen to join one or many of her support groups.
Thank you, Michelle. Yeah, that's so true, is that wherever you are in the progression of managing ILD, we noticed through this for initial diagnosis, and it was skewing a bit for folks who were having lung transplants. So we wanted to make sure that we were focusing on the lung transplant journey. So we recreated a lung transplant education series, which is it's so valuable of all aspects of a lung transplant: medications, nutrition, what's evaluation, what's the surgery like. And so that has been proven to be very, very valuable. Also, I talked about our care partners in this systemic, really, movement forward for our patients and families, and how important our care partners are. So we bring together our care partners to freely talk about. They're going through their own journey, and sometimes not always comfortable talking with their loved one. So this is definitely a journey in itself. We want to make sure we fulfill that through our care partners. Through this process, we're learning more and more of our veterans living with ILD. So we create a veterans ILD meetings, and we have our veterans come in. We're one of only 2 in the US. If you're a veteran, get connected. This group is incredible, and we are learning a lot and making sure we're getting connected with the information we need. Project positivity and frame of mind and mindset. It doesn't negate the reality of everything, but I tell you what, we come to our project positivity and we have a good laugh, jokes, everything. It's just so great. And one of our patients run it, and he's just a lovely, lovely man. And then we, through this process, we lose our loved ones. And so we've created such a strong network. We want to make sure our folks are still connected and supported when they lose their loved one. So helpful resources. We cannot do this in a silo whatsoever. And the collaborative partnerships we have, and we've worked with Temple Lung Center proudly for many, many years, and done incredible work in supporting the patient care partner and entire ILD community. So this is some information that we have, and you could check out all the information on our website. Of course, I have Wescoe, but also we have a support network in Pennsylvania called Pennsylvania IPF Support Network, that we're connecting our care centers in education and support and awareness. So this is invaluable. The other wonderful organization is Pulmonary Fibrosis Foundation. Again, we do a lot of collaborative projects with PFF, and they're incredible. And so make sure you get connected with them. They have great resources as well. American Lung Association absolutely has information about ILD. So if you want to peek at this, again, we always talk about one step at a time, right? Just do the best you can. And lastly, PF Warriors, they have a lot of online resources and really educationally based. And so that's another resource as well. They're through social media as well. If you have any questions about getting connected, please do reach out anytime. Temple Lung Center has quarterly sessions 4 times a year. And so another connection that we can make sure people are supported. So thank you so much. And please let me know if you have any questions about that. Next, we are going to have Q&A with Dr. Criner. Michelle's with us, Dr. Ajmeri, Kevin's with us, and Dr. Rachel Criner is with us as well. We do have questions along the way, so please do reach out, and we have that. I mean, look at this. This is wonderful. We have experts here with us to help us along the way. So now, I'll start off with this, Kevin. Is Temple accepting patients with lung transplant in a lung transplant program, and then a little tangential with clinical trials?
Sure. So, you know, a lot of patients are either referred as a self-referral or referred by their local pulmonologist. So, you know, we're happy to evaluate any patient. There's not a formal referral process. You know, what's important to know that after that new patient appointment with one of our Temple docs, patients who are thought to be sick enough to need a lung transplant and who do not have any obvious comorbidities, they would then be referred for a transplant evaluation. And after that point, together, the group of clinical experts determine that patient's case. A, are they sick enough? B, do they have any other comorbidities that would preclude transplant? And if not, at that point, patients would be then listed for transplant. So we're happy to evaluate any patient, 215-707-1722. And you can ask to speak to one of the transplant coordinators to kind of start that process. Jennifer is a resource. Michelle is a resource. I'm happy to do a chart review myself. So
thank you. Excellent, Kevin. Thank you so much. There's another question. Kevin, can you repeat that phone number real quick again?
Sure. 215-707-1722.
Perfect. Thank you very much. Next question. This is for the open panel. Do you recommend continually monitoring your oxygen saturation levels with a ring, one of those monitor rings, or other devices so we know when our levels are dipping?
So
Sure. Oh, Kevin, go ahead.
yeah, so you know, I think assessing, you know, especially for interstitial lung disease, what I always tell our patients is kind of identify a level of activity that you're able to do before you get short of breath. And then if you start to feel that you can no longer do those levels of activities, that would be a very important conversation to have with your pulmonary provider. You know, certainly I think spot checking your pulse ox during the daytime. Here's my oxygen if I'm sitting still. Here's my oxygen while I'm exerting myself. Here's my oxygen level when I'm really stressing myself to get a sense. But I fear that sometimes patients get overwhelmed and obsessed with monitoring a single number. Really, all the providers, and you see everybody shaking their heads, we're here. We want you to have the best quality of life for as long as possible. So spot check it, but don't obsess over it.
Perfect. Yes, very true. Very true, Kevin. Thank you. One of the questions is a person, they're newly diagnosed. How do they know what it is and not an exacerbation? So maybe understanding about exacerbation, when you can identify that and make the next steps needed.
Yeah, so typically you'll have kind of your baseline symptoms. So your symptoms that, maybe every day you're short of breath when you take out the trash, or maybe you're not short of breath at all, but you know that you have interstitial lung disease. And then it can happen quite suddenly, or it might take a couple days where all of a sudden you're noticing, hey, I can't do that activity anymore, or I'm really struggling. Like, I can't take out the trash anymore. I can't go up my staircase anymore. You notice there is a sudden change, whether you yourself are noticing it, or maybe family around you is noticing that you're starting to struggle. It could be worsening shortness of breath. It could be worsening cough, or more maybe significant fatigue. So it's usually not a slow progression. It's usually, pretty obvious where, like, I have to call my doctor. And if you ever have any change in your symptoms, you're never wrong just to call us or call your doctor. And then we can assess over the phone, is there something that we can do for you over the phone? Or do we actually need you to come to the hospital or maybe an urgent care setting to get some preliminary testing? Just because you're more short of breath or your cough is worse doesn't necessarily mean it's an exacerbation. It could be a myriad of other causes, but it always in the back of our mind. So if you ever have any worsening, just call your doctor, and then they'll either do some testing or preliminary things over the phone.
Excellent. Thank you, Dr. Criner. Dr. Ajmeri, what's the most amount of liters that for portable oxygen concentrators can provide? This question comes a lot in our meetings. Do any go above 2 to 3 liters? I would say that's for POC.
Yeah. So generally they do. I think the antigen goes up to 6, but really when you go higher than 3, it's going to be pulsed most of the time. So you're not going to get the continuous flow. And some patients, they can tolerate the pulse, but sometimes it's, the continuous flow is really what makes them feel better. So it's kind of the risk benefit of having that portable concentrator with the pulse flow versus, kind of dragging the tank along with the higher amount of continuous flow.
Yeah, the 6, Dr. Ajmeri, goes up, the antigen goes up to 6 continuous, but it's heavy. It's 14 pounds. And it's most times not covered by insurance.
Right.
Mm-hmm. Yeah. And isn't it like a suitcase? Like you literally have to, it's very big. Yeah. Michelle, this is a good question for you. If you stop pulmonary rehab and then experience worsening symptoms, can you restart, especially if your condition has gotten worse?
So you could definitely restart pulmonary rehab. Obviously, we want to make sure that your symptoms aren't getting worse because the disease is, progressing rapidly, but you can, the insurance will cover a certain amount of pulmonary rehab sessions, and most programs do have maintenance programs where after you reach the limit of what insurance will cover, they have a maintenance program where you can go anywhere from 2 to 3 times a week or even more. You just have to pay a fee, a monthly fee or a weekly fee.
Mm-hmm. Mm-hmm.
But definitely pulmonary rehab and staying active and any kind of lung disease, but especially interstitial is important, especially because, we need our legs. Our legs help us breathe. Those are the muscles that we use to help us breathe. So the less active you are, you're going to be even more breathless on top of having the interstitial lung disease.
Excellent, Michelle. Thank you. So this is a question for Dr. Criner and Kevin. Are skin cancers such as basal squamous and stage T1A melanoma with no chemo or radiation needed disqualifiers for lung transplant?
So for our program, that would not disqualify you from lung transplant. What I tell patients to is, instead of focusing on maybe what you think would be an exclusion for transplant for you, saying, okay, I'm this age, I don't think transplant is something considered for me, or I have had this in my history, transplant's not for me, then I'd say that that's our job to do. So if transplant is any question that you have, just come and get evaluated, and then we can go through, maybe what is a true exclusion and what is not. A lot of the requirements, some of them do evolve and change over time. So just because you might have been told at one place doesn't necessarily mean it's a no forever at that place or a no at Temple. So, but to answer your question, no, that shouldn't disqualify you.
And to add on Dr. Criner's point, I think she nailed it right on the head. If Center A says you're not a candidate, I strongly encourage you to speak to Center B and Center C to get others' opinions. Guidelines are guidelines, but each center is going to have their own inclusion and exclusion criteria. What I also want people to realize is that skin cancer tends to be more of an issue post-transplant, unlike other types of cancers. So, I always talk with our patients at least every 6 months, seeing a dermatologist on a regular basis. So if skin cancer was an issue pre-transplant, it may be an issue post-transplant. So right out of the gate, you should maintain that close dermatologic follow-up.
Mm-hmm. Excellent. Michelle's in clinic, so she sends her best wishes and had to step out. So she's off treating patients as we speak. We have another question. These are a lot coming in, so I apologize if I'm not getting to you. This is a question really for the whole panel. We have a person who's moving into a home where the basement has mold, and we hear about this for sure, which is going to be remediated by a professional. The air is going to be tested again before moving in, and it dehumidifiers will be in place. What other precautions should this person be taking?
I can take that one. So I guess it kind of depends. Is the mold already something that's leading to the lung disease? We talk a lot about mold because it can cause kind of an exaggerated response to the lungs, like hypersensitivity pneumonitis, which is a type of interstitial lung disease. So for patients who have that, we spend a lot of time talking about, cleaning the house professionally with remediation. Really, it's uncommon, but we, in kind of these extreme situations, we will talk about home remediation and air quality testing. One place that that they don't generally test is the duct work. So if that's something that is leading to your ILD, then excuse me, then I think that's something also to look into. But otherwise, that's a very thorough job to prevent any sort of mold exposure causing any lung disease.
That's great. It sounds like all of the steps are being taken for this person, so that's good. Very active, proactive actions. This is for open panel. What do you feel about prednisone strategy for to diagnose, then lung scan, PFT? This person is early onset and he or she just got diagnosed.
So it does depend. So interstitial lung disease, from I think one of my first or second slide, it talks about how there's inflammation, but then it can progress to fibrosis. So it's hard to answer that question because it really depends where is that person within their spectrum of interstitial lung disease. So prednisone's an anti-inflammatory, so it can help with the inflammation, but once the fibrosis, the scarring portion has happened, prednisone's not going to help for the actual scarring part. So it's not a strategy for diagnosis. It can be a treatment option for inflammation part of interstitial lung disease. So I probably would not rely on prednisone or a steroid response for kind of workup of your disease, if that answers your question.
Mm-hmm. Okay, great. Thank you, Dr. Criner. So someone's taking Esbriet. Do you have to stop taking Esbriet for a clinical trial?
I can also answer that one. So no, so Esbriet is standard of care. OFEV is also standard of care. We have about 10 to 15 trials right now for interstitial lung disease that are open or will about to be open. If you have, there are certain trials that if you're on Esbriet, you're excluded from the trial, but we also have a huge group of other trials for patients who are on Esbriet who would stay on Esbriet and still be in the trial. So the answer is no.
Okay, great. There's so much out there, and especially with clinical trials is just incredible. We're going to wrap up here. We've had an incredibly informative 2 hours and 45 minutes of Very important information. We talked about what is ILD. Thank you, Dr. Criner. We talked about symptom, oxygen management. Dr. Ajmeri, thank you so much. The polls, here are the polls. You see some of results here. This really helps us really assess, reassess of things to maybe focus on, and things that we're doing okay with. So this is very helpful. So thank you for being a part of the polls. And so if you want to look at that, that's there for you. And we talked about pulmonary rehab. We talked about research, clinical trials with Dr. Criner. We talked about lung transplantation and the history and everything. That's Kevin. Thank you so much. And lastly, we talked about supportive care, how really tremendously important that is. I have to say that because that's important work. It's important work, very, very important part of the process. And so you have any questions? Thank you so much for attending. We have to have a big thank you for Kelsey, for Kelly, for Temple's IMS program, who helped facilitate this tremendous webinar. This is a lot of the background work that they've worked so hard on this. So this is a huge thank you to them for all their hard work. Thank you for attending. There will be an email coming out with further information. If there needs to be an appointment, scheduling, support groups will be shared for all attendees. And so this is recorded. So make sure you have that information. So here we will close. We will close. Feel free to reach out. Thank you so much for Boehringer Ingelheim for your support for our webinar today. We appreciate you along the way, on every step along the way. So thank you. So thank you, everyone. Yes, have a blessed day. And we will hopefully see you soon. Take care, everyone. Reach out anytime.